Assalamu alaikum. The article of this week is titled Accuracy of Static Guided Endodontics for Access Cavity Preparation with Bulb Canal Obliteration. It's a randomized controlled clinical trial done by a Chinese group and published in BMC Oral Health in 2025. In the past 9 years, static guided endodontics has emerged as an alternative approach for PCO, and this technique employs tooth supported guides or templates to enhance the precision of root canal location, resulting in a more predictable outcome. And the primary objective of this study was to rigorously evaluate the accuracy of guided endodontics for PCO, and the secondary objectives included the assessment of pain during treatment and clinical outcomes. Now, moving to the methodology, participants were recruited from the outpatient clinic of the Department of Endodontics, spanning the period from July 2020 to March 2022, and the inclusion criteria were as followed: bulbal and periapical lesions associated with permanent tooth, teeth displaying bulb canal calcification in the coronal or middle part and canal curvature angle of less than 30 degree, and teeth without root canal treatment and crown restoration. And for the sample size determination, it revolved around the primary outcome measure of accuracy between planned and executed endodontic access cavities, and the sample size of 40 teeth per group was established. And the treatment procedure was administered by a single experienced endodontic specialist for both groups. The 80 included patients were randomly assigned to the static guided group and the freehand group at a 1-to-1 ratio, and the outcome variable assessors were kept blinded to the allocation. And for the access cavity drilling, in the static guided group, patients underwent static guided access cavity preparation with 3D printed endodontic guides. A low diameter burr was employed in a picking motion to drill through the sleeve, achieving the desired path length. Following guided access cavity preparation, the impression of the access cavity was taken using a BVS impression material, and an indirect impression scanning of the access cavity was executed and aligned with the preoperative model to assess the qualitative precision of static guided endodontics for PCO. And for the freehand group, a contemporary freehand access cavity preparation techniques were applied using endodontic microscope under rubber dam isolation. And after drilling the access cavity to the target path length, indirect impression scanning was conducted and registered to the preoperative model. And then standard endodontic procedure was performed under rubber dam isolation for both groups. Now for the outcome variables, starting with the primary outcome, which is the accuracy assessment, upon completing access cavity preparation, indirect impression scanning of the access cavity was performed and aligned with the preoperative model to gauge the qualitative precision of static guided endodontic for PCO. Subsequently, a line was aligned along the central axis of each access cavity, and the highest angle between the planned and executed access paths was recorded. For the pain during treatment, the pain levels were evaluated using the visual analog scale, and approximately 1 year post-treatment completion, participants underwent both clinical and radiographic assessment. Now moving to the results of the primary outcome, in the static guided group, the average linear deviation was 0.14 plus or minus 0.08 millimeter at the coronal entry point, and 0.35 plus or minus 0.16 millimeter at the apical point. And the angular deviation was 1.75 plus or minus 0.30 degree. And in the freehand group, the average linear deviation was 0.62 plus or minus 0.15 millimeter at the coronal entry point, and 1.06 plus or minus 0.39 millimeter at the apical point. And the angular deviation for the freehand was 3.38 plus or minus 0.44 degree. The statistical analysis demonstrated that the deviation at the coronal entry point, apical point, and angular deviation were significantly lower in the static guided group compared to the freehand group. And for the secondary outcome, which was the pain levels, the results indicated that patients in the static guided group appeared to experience lower pain levels than the freehand group. However, no statistically significant difference were observed between the two groups. And the clinical and radiographic evaluation were performed approximately 1 year after treatment completion, and the statistical analysis revealed also that no significant difference between the two groups. A major limitation of this study is that they had two meta sleeves for the static guide, which necessitate the removal during metal sleeve replacement, which could introduce a potential bias. But under the limitation of the present randomized controlled clinical trial, the static endodontic guides exemplify a reliable approach for in vivo bulb canal obliteration.